Hi everyone. So it's 6 o'clock Eastern Standard Time, so I think we're going to get going. Uh, First off, just want to welcome everybody to, I guess, what's now our second Facebook Live event with Lupus Canada. I'm Dr. Mark Matsos. I'm an Associate Professor of Medicine at McMaster University in Hamilton, Ontario, and I'm a clinician with the McMaster Lupus Clinic. First off, I just wanted to thank Leanne and the good folks at Lupus Canada for having me back to do another one of these sessions. Our first one was near the end of March, and wanted to thank everybody who contributed feedback to that. And I'm happy to be back to try and give another brief update as to what's happening, particularly in the COVID-19 era and things pertaining to patients with lupus and the issues that all of you have identified and questions that you've sent into Lupus Canada over the last week or so. So thanks again for your participation, everybody, with that. I do want to take a minute and recognize that yesterday was World Lupus Day. So lots of activity on my social media feeds and Twitter about people doing all sorts of great stuff around the world in terms of fundraising and highlighting awareness of this illness. So I thought that was great. And the other thing I wanted to highlight as well is that this coming Friday, May the 15th. I want to remind everybody to put on purple for lupus. You can see the shirt over my left shoulder here. Some of you may have that t-shirt, just again in an effort to try and raise awareness for lupus and the issues that all of you are going through. And if you're interested in procuring one of these t-shirts, I think you can get one through Lupus Canada. Leanne will tell me if I'm incorrect on that, but you can always reach out to the folks there if you'd like one of your own. So it's been about, I think it's been about 8 weeks since we last spoke, and lots have changed in terms of what's going on with COVID. We've got about 30 minutes till about 6:30 tonight for me to offer folks a brief update. Generally speaking, I want to remind everybody, while I'm sure everybody has lots of pressing kind of questions about their own unique situations, because I'm not familiar with the clinical scenarios and life situations you find yourselves in. I am unfortunately going to shy away from offering any specific advice to any one individual. So you are going to hear me talk more very broadly about some of the issues that have been raised, and certainly if you have any questions about any of the information I provide tonight to you and how it specifically pertains to your own situation, I would again encourage you to speak with your own medical team just to get some more clarification on any of those things. Oh, good. Leanne's telling me that you can get your put on purple t-shirts at Lupus Canada. So great. I didn't misspeak there. Okay, so out of all the questions that were submitted over the last week or so, and in my own conversations over the past few weeks with my own patients with lupus through our virtual visits, because we're still not really doing in-person visits at this point because of clinical restrictions, at least locally here in Hamilton with regards to COVID and how we're able to look after outpatients. Three sort of broad themes again have emerged, similar to what we talked about the last time we did one of these sessions. So I've kind of broken them down into broad categories, and I'll chat a little bit to the best of my knowledge and as it pertains to my own interpretation of whatever data is out there. And I will say these are my opinions and my opinions alone on this, and you may find other information or other viewpoints out there, which I think is important as well to have a kind of good, well-rounded approach to these questions. So first thing we're going to look at is what the heck's going on with Plaquenil. Because at this point, about 8 weeks ago, that was a big stress point, I think, for a lot of us, both for our patients, of course, also for those of us who prescribe it to patients with lupus to keep their disease well controlled. And there's some good news on that front. The second large group of questions came from how is this illness seen to be impacting lupus patients specifically. And I've got a little bit more data to share with you from an initiative that had just been launched the last time we did one of these sessions, which is a global rheumatology registry for patients with all sorts of different rheumatologic diagnoses who unfortunately were infected with COVID, but also were then tracked to see what their outcomes were. And there is a population of lupus patients within that grouping that we'll talk a little bit. I've got some updated data as of a couple weeks ago to share with you on that. And then one of the other big questions, and I think this is top of mind for a lot of people as this drags on and on and on, is what do we do about trying to get back to work? At least for those of you who were able to be employed, who either were still working or had the opportunity to leave the workplace because of concerns of infection risk, or perhaps were laid off. What does that look like? There were a lot of questions based on that moving forward. So those are the three kind of broad areas that we'll talk a little bit about here. So first off, let's start with Plaquenil or hydroxychloroquine, as some of you may know it of. So if you recall, at the beginning of the outbreak of COVID-19 and this pandemic, very early on, Plaquenil was identified as an agent that potentially would have important therapeutic benefits to the general population out there of people who had become infected with COVID. And this wasn't entirely groundless. Certainly in the laboratory settings and sometimes in animal models, the compound hydroxychloroquine and its cousin drug chloroquine, which are in the anti-malarial family, had been shown to potentially be of benefit. The challenging thing is, though, of course, that just because something works in the lab doesn't always translate to it, working in the real world when it comes to complex patients and complex diseases and complex infections. And the initial kind of push that went on that led to a run on this drug being prescribed, all around the world, and especially in North America and down south, and the stockpiling of these drugs was based on, in retrospect, what was probably some pretty flawed. Concerningly flawed data in terms of a very small, not really well-designed clinical trial that suggested that this drug could be of benefit. And, it took a little while for the scientific community to have a look at that and sort of dispel, I think, some of the clinical results that have been published there. Unfortunately, a lot of the damage had been done. Now, what I will say, subsequent to that, there have been, a multitude of other studies, potentially equally with issues as the original study that showed benefit, but which study after study is now demonstrating that there may and is unlikely to be a true clinical benefit of hydroxychloroquine in COVID, at least when we're speaking about the general population. That's still not a definite. We still don't know for sure, but I would say that medical opinion is certainly slanting in that direction. And so, it's unfortunate on one level because it means it removes a potentially easy to make effective therapy for people that get infected. But on the other hand, we're starting to see less of a run and a less of hoarding, so to speak, of this medication. And that, combined with a real increase in production of a hydroxychloroquine, means that there really the era of us having to worry about an acute shortage of this drug is quickly coming to a close. And hopefully what most of you have found, if you've tried to get a prescription for hydroxychloroquine, at least over the last couple of weeks, you're finding it not to be as much of an issue. And we're projecting moving forward that, at least for our Canadian lupus patients, and I think probably true throughout North America, but particularly in Canada, we are not anticipating the same sort of demand and the same concerns around shortage. Now, that being said, you still may only be able to get a 1-month supply at a time of this stuff, and a lot of pharmacies, at least in my understanding, have resorted to that just as a means of protecting against possible supply issues in terms of them able to access their suppliers and have stuff in stock. But you should no longer be experiencing an issue where you show up to a pharmacy and they aren't able to get you anything from that standpoint. So hopefully that's very reassuring. Now, I will say that despite the fact that the trend seems to be moving, away from antimalarials as being effective in COVID, there are still over currently 40 clinical trials on the go right now looking at the use of this drug in COVID. So could we come back to a situation where maybe some new data emerges where perhaps it does look like in very particular situations hydroxychloroquine may be effective? Yeah, that's possible, but I certainly think we're weeks, if not months, away from knowing any of the real answers as far as that goes. Personally, what I'm most interested in is looking at the use of the drug in sort of a post-exposure situation. So I think there's enough data, at least in my reading of what's been available to me, that suggests that in the most critically ill patients with COVID, hydroxychloroquine is probably not playing a role necessarily in helping them get better. But I think where there still may be a role, or at least what I'll be interested to see, is in folks who may have had an exposure to somebody with COVID and are at high risk of being a carrier in early infectious stages. Whether sort of a preemptive strike with this drug actually helps to reduce the severe clinical outcomes that we see in some patients. One of the big issues I think that we're dealing with in terms of why it might not be effective is that when you look at the levels of the drug in the lab and in animals that had to be achieved for hydroxychloroquine to have good antiviral effect, it's just not safe to get the drug levels to that state in the human body. So the standard dosing of hydroxychloroquine that many of you are going to be used to in terms of treating your lupus, which is somewhere between 5 and 6.5 milligrams per kilogram a day, and generally speaking not over 400 milligrams in a given day, are actually too low to generate enough of a blood level of hydroxychloroquine that it would equal what the effective blood level was in lab settings. And certainly what we're seeing when it's being given in clinical trials, it is being used at higher doses than what we typically give to a lupus patient population. And we are starting to see a higher rate of some very rare toxicities that we almost never see in lupus populations. And so some of you may have read, for instance, about some of the impact and concerns about antimalarials, hydroxychloroquine and chloroquine on heart rhythms and arrhythmias. And I've had several of my own patients sort of approach me with those concerns. And certainly that is not something that we see very frequently at all in lupus patient populations when we're using lower doses of the medication. So we're starting to see some unique rare toxicity things in study patients where the drug's being given at significantly higher doses that I think may preclude the use of the drug longer term in terms of its effect in this infection. So that right now sort of at this point, and of course everything's subject to change with this virus as we continue to learn about everything. So at least as of today at 6:12 p.m., that's sort of at least my take and my impression of the data as it pertains to hydroxychloroquine in COVID in the general population. And I think the take-home message here, though, is that we've seemed to have the royal we seem to have stabilized the supply, and that there should not be significant risk of shortages in Canada moving forward in terms of patients being able to access that particular medication. So we'll leave it at that with Plaquenil. All right, second broad category of or broad topic area. What do we know specifically about the impact of this virus on lupus patients? Are they different than the general population? Are they different than other rheumatic patients? Does it matter if a lupus patient is on hydroxychloroquine or not in terms of how this virus affects them? So I think when we first had one of these conversations about, again, a couple months back, at the time, the global rheumatology registry that was tracking patients with any rheumatic diagnosis, whether that be rheumatoid arthritis, lupus, psoriatic arthritis, really had just been launched. So we had very small numbers. And at that point, there were only 17 lupus patients enrolled in that particular patient registry. So as of the middle of April, which is sort of the last time that we were able to see some in-depth published data on that cohort, more has certainly been accrued since then. We just don't have the numbers in front of us to review quite yet. They're in review for possible publication in the short term. But as of mid-April, we were up to now 80 patients with lupus who had confirmed COVID-19 infections, and could be from anywhere across the world. And had been entered into the patient registry for us to look at and track. Now, when you look at those 80 lupus patients, 64% of them, and that equals 51 out of 80, were on an antimalarial, so either Plaquenil or chloroquine at the time of their COVID infection. So the majority of them were actually on antimalarials and still had an infection. And when we looked at the differences between the group, the lupus patients that were on Plaquenil or an antimalarial, and the group that were not on one of those therapies, there actually was very little difference, at least in the initial clinical outcomes for those groups. So small numbers, but when you looked at them in comparison, about 50% of them in both groups ended up requiring hospitalization because of COVID. And a similar, the same percentage in both groups also required escalation of therapy, for instance, admission to an ICU setting or intubation because of more severe features of COVID. So unfortunately, it doesn't look like Plaquenil necessarily makes a difference in the general population. And also, if you're a lupus patient, whether you're on Plaquenil or not, at least in terms of your experience, if you were to become infected with COVID, small numbers, but it doesn't appear that it has a protective effect. And so I think this is sort of something that a lot of us in the rheumatology community, at least in my circle, have recognized. And one of my big take-home points to my folks with lupus and some of my other arthritis sufferers who are also on Plaquenil is that unfortunately you can't kind of get a false sense of security from that standpoint. Plaquenil does not appear to be protecting you, whether you're on, if you're on it compared to folks that are not on it. So unfortunately, there does not appear to be an advantage there. In terms of some other data around lupus in particular, and in terms of how are lupus patients faring with regards to outcomes, like mortality, and these other things, we don't quite have that data yet, at least in lupus patients compared to the general population or compared to other rheumatic disease patients. That's coming. We just don't have it yet. Generally speaking, though, when we look at that entire cohort, and this is any patient with a rheumatologic diagnosis, and at the time that the data cut happened, there were well over 650 patients across the board with different diagnoses that had been identified. What we were seeing is that about 9 to 9.5% of those patients had unfortunately passed away, which it would appear to be at least on par with a lot of geographical areas right now in terms of what we're seeing in mortality rates with this illness, unfortunately. And about 44% of that population had been hospitalized because of COVID as well. So maybe slightly higher rates of hospitalization, mortality rates look the same, but otherwise, at the moment at least, there does not appear to be a big distinguisher in terms of patients with rheumatologic diagnoses and outcomes with COVID infection. And similarly, we still don't yet have a full feel in terms of what's the impact of patients being on other or being on immunosuppressants. Remember, Plaquenil isn't really an immunosuppressive therapy. At least that's not how we think about it. It's very different than other drugs that some of you may be exposed to, as we talked a little bit about the last time. Things like, for instance, Cellcept or methotrexate or Imuran or prednisone. So we're still not sure what the impact of being on those therapies, and particularly steroids, are in terms of infection risk and outcomes. Again, as more data gets accrued, hopefully we'll be able to have sufficient data to do that kind of data cut and really delve into that to give people a better picture of their risks. At this point in time, what I continue to counsel my lupus patients on is that if you are on any of those medications, you are immunosuppressed, and pragmatically speaking, while we're concerned about everyone, of course, we're particularly still concerned about patients who continue on immunosuppressive therapies in the context of this infection circulating, and we want you to take all necessary precautions that you can, as really we all should. So that was one of the other common questions that continued to come up with this one is what's the impact of being on more advanced immunosuppressive therapies to control disease. So I think those things still hold. All right, and then the last sort of broad basket of questions really fell into the category of well, now what? And we've been living with this now for over 2 months. And what's the future look like? What about getting back to work was a pretty common one. And so this again is pretty challenging, because the decisions that each of you who are on here make with regards to steps you take in terms of whether or not to return to the workplace, or if you're living with someone who is an essential worker and is going out to work every day and then coming home, what kind of precautions you elect to take is going to be a very individual decision. And at the end of the day, a lot of things are going to come into play in terms of determining, what the risk is of returning, in particular to a work environment, and that's going to depend on how active your lupus is, what particular therapies are currently on board in terms of treating your lupus, what's the nature of the employment, what's the nature of the workplace that you have to go back to, potentially, at least geographically, in terms of how well can you control proximity to other people. What's your own personal necessity to have to go back to work from an income stabilization standpoint. The reality here, unfortunately, as well, there's been a lot of support, at the federal government level for people that unfortunately have been laid off or have been unable to work. I don't know that pragmatically that's going to be an indefinite thing, and so some tough decisions, I think, for each of you individually are going to need to be made. And what I really want to highlight here is that I think it's important that you have these discussions, in conjunction, first of all, with your rheumatologist, who knows you best and knows your disease situation best and your own unique risks the best. And in your workplace, the human resources people, if that's available to you, or your workplace, in terms of pragmatically, how can you best be accommodated to try to reduce as much as possible the risk of exposure. And I think a few things need to enter into the conversation here. One is that we still don't have an effective therapy. Right? There's no treatments yet that have been documented to significantly impact on the clinical course in someone who has this infection. So we still don't have that. Two, we are a long way away from vaccination. And so, there's a lot of talk about, when a vaccine comes. And I like to take a step back and I say, well, first of all, the first step is if a vaccination comes, and if we get something, how effective is that? And we are, as many of you have probably read, if you're doing any reading or research around this, at least, frankly, a year, if not longer away, if a vaccine comes to fruition. And so the reality of that is that while our numbers in the community are certainly dropping, at least in southwestern Ontario, where I am here in Hamilton and the western end of the GTA. What we're seeing is that when other locales start to open up again, and you've probably seen reports from places in Europe like Germany and South Korea, all of a sudden we see spikes again. So the virus is still out there. It's not going anywhere. It's not going to disappear. We're going to need to learn to live with this for a prolonged period of time. It's looking like, and without appropriate precautions being taken, once we get the community spread down, it's very easy for this to rebound again. The nature, the success of sort of these lockdown measures we've all gone into is that in many locales in Canada, for the most part now, we seem to have gotten a control on community spread, but that could potentially be a very short-lived victory. And so pragmatically speaking, if that's the case, and if we're not going to have a vaccine in the short term, and we don't have any yet effective treatments clearly for this is something we're all going to have to learn to live with. And what that means is a lot of the behaviors that we're starting to adopt, wearing a mask, wearing gloves in certain situations, social distancing, is here to stay, and it's here to stay for a while. And also remember that the initial goal of these lockdown measures was not necessarily to prevent us from ever being exposed to this virus. It was to make sure that the population at large was not exposed to the virus in one big felt peak, so as to overwhelm the healthcare system. Now we may have avoided that, but like I said, it's still circulating. It's still around. Hasn't gone anywhere. And so for those of you who are being asked to return to the workplace, or who would like to return to the workplace, pragmatically speaking, I don't know that we can, say to people, well, look, you're just going to have to be off of work for, until we come up with some solution, if we ever come up with a solution in terms of a vaccine or a treatment. The reality is there's no timeline for this. So I think at some point, those of you who work and who want to work are going to need to have these discussions with your workplace, with your healthcare providers about what's the best strategy for you to be reintegrated back into the work environment. What are the concrete steps that can be taken, in your work environment to protect you? And certainly, you're going to need to make sure that you're taking, precautions yourself, including wearing a mask and being, socially distant as much as possible in those situations to keep yourselves well. Generally speaking, and this is something I've started to grapple with, because initially as part when this peaked for many of my patients, and particularly with lupus and on immunosuppressives, we were writing letters and advocating for them to leave the workplace for at least 8 to 12 weeks while we went through that initial spike of the illness. And at least in Ontario now, we are starting to seeming to be coming to the other side of that. So people are going to be looking to go back to work. And so what I've been telling my own patients is, if the option for remote work is still something that can be made available to you and is feasible, I continue to strongly recommend that as a primary measure. For those of you, unfortunately, where that's just not an option, and that may be a significant number of you, especially once things start to open up, and if we start to see kind of benefits being clawed back for people that have been out of the workplace, I think those are going to be some very frank discussions you have to have. And unfortunately, I don't know that I can give you any more guidance at this point, at least beyond having those conversations and following the instructions of public health. So those were the three big categories of kind of questions that folks had that had sent questions into Lupus Canada. And certainly, the flavor of the conversations that I've been having over the last month or two with my own patients that I look after at the McMaster Lupus Clinic. We've got about 2-3 minutes left here. If anyone wants to raise another question on the message board here, I can certainly try to have a look here just to see if there's anything else I can answer. I can answer clearly here. Yeah, so lots of questions about other kind of immunosuppressives and the impact of lupus patients who were hospitalized and or needed more advanced treatment, even though they were on Plaquenil. Were any of these patients on methotrexate or Imuran? The answer is they may have been. We don't, unfortunately, we don't know what that data cut is. We don't have that specific level of data right now in terms of trying to look at, even if they were on hydroxychloroquine, whether there was a confounder in terms of being on other stronger immunosuppressives that may have affected their hospitalization. Okay, so it doesn't look like anything else coming down through here. So with that, I'll say thank you again for tuning in. Remember to to put on purple this Friday, in support of Lupus Canada. If you're social media inclined, maybe snap a photo and tweet it at the Lupus Canada folks, or post it on the Facebook page here. If you'd like a shirt, you can contact Lupus Canada, and I'm sure they'll figure out how to get you in one as well. Several of my patients on the chat here are asking about future appointments. And the answer is, at least at McMaster, at the Boris Clinic, where you come and see me, we are still shut down. They have not told us yet when we're going to be able to start bringing patients in more routinely for routine care. So anyone who has an appointment, it will be converted to a virtual visit until you hear otherwise from us as well. For those of you for who, I have one last question here. Any advice for frontline healthcare workers? I think beyond what I've already told you, which is, if you're you need to talk to your colleagues, particularly if you're a nurse and you're on the real front lines of this, making sure you've got access to all the best PPE, perhaps being put in clinical scenarios where you're less likely to be exposed to COVID patients in terms of transmission risk, I think are things that would be pragmatically that you could advocate for yourself, that would allow you hopefully to stay in the workplace if those things were possible for you. All right, with that then, I will say thank you for tuning in, and hopefully we'll get you all stay well and stay safe, everyone, and hopefully we'll get a chance to do this again sometime soon. Take care all and have a great night.